and I'm going to look for visible signs of edema and moles, scars, or any other factors that will affect the object. And I'm going to turn the novoscope on. I'm going to make sure it is at medium sensitivity, which it is. And for the cervical portion of the instrumentation, I'm going to bring it in closer so that it's at the proper width. I am going to have the tip of the sensors having a good seal, like so. And it shows slight depression of the skin around the sensors. The sensor stays perpendicular to the skin, and if there is a sensor break over the spine, it's going to be fairly quickly over and back movement. And now that I'm in thoracic, I'm going to go ahead and set it wider. The break will occur in a short distance, less than one segment. It must be repeated 3 times if there is a break. Inch of the hot side, the peak of the break points to the hot side of the skin. I will mark below the sensor for the cervical spine, so mark it above the sensor here for thoracic. Just kind of running my fingers along the spine. And if I'm looking for boggy feel, somewhat soft and squishy, and wherever I feel that bogginess and edema, I'm going to go ahead and feel for pain on palpation, and it'll usually be along the inferior tip of the spinous process. Now for the SI joints, I'm going to go ahead and come down here, and once I decide which SI joint is affected, I'm going to go ahead and feel for tenderness at the upper joint, which would be a PI, or the lower joint, which would mean an AS, or if there is tenderness along the whole joint, it would mean that could be an EX. And if there is no tenderness, if there's no tenderness associated, particularly if they have like deep inguinal pain, then it may indicate an IN. With the occiput, and I'm going to do laterality of the occiput along the atlas. Okay, so for lateral tilt, I am going to contact the occiput on the mastoid and the C1 TVP, and I'm going to laterally flex the patient's head and then come back up. And the contacts on the side of lateral tilt should close down. If not, the occiput is lateral to that side. An A to P glide, I'm going to contact with the thenar calcaneal portion of each hand, posterior to superior to the patient's ears, approximately at the parietal bones near the lamboidal suture. So I'm going to isolate the side of interest, roll the head to the right or left based on lateral tilt. I will not bend the neck. And for posterior to anterior glide, I will press P to A, feeling for springy end play. Lack of end play indicates PS occiput on the side you are testing. A to P glide, I would use the hand on the side that I am testing, right side, right hand based on lateral tilt. I would use the soft pisiforms, hypothenar over the supraorbital ridge on that side, isolate the side of interest, roll the head to the right or the left based on lateral. Pull A to P, feeling for springy end play. Lack of end play would indicate an AS occiput on the side I am testing. Do left hand over left hand here, and then right hand on the right side, and here. For posterior to anterior rotation, I'm going to contact the mastoid and TVP of the atlas, and I will rotate the patient's face away from the contact side. I will feel for the mastoid to move forward. It will be very subtle. The lack of movement would indicate a posterior side of the occiput. Applying this information to the listing, RP, RA, or LP, LA. If the listing is on the right but the mastoid is posterior, the listing side is anterior. So now for the atlas portion of the motion palpation examination, I'm going to go ahead and start with laterality, or lateral tilt. So I'm going to contact between the tip of C1 and the C2 TVPs, and I will laterally flex the patient's head. The TVPs on the side of lateral tilt should close down, and if not, it would be a C1-C2 atlas lateral to that side based on right or left. So now for the superior-inferior portion of the atlas, I'm going to have my patient stand there so I can observe how her head and neck relationship is with each other, and she's going to close her eyes, lift her head up and down a few times until I say stop, and stop. And I am going to check for whether the chin is high or the head is forward. If the chin is high or forward, it is likely an AS, and if the chin is low or the head is translated posteriorly, it would be an AI, atlas. So for posterior/anterior movement of the atlas, I'm going to go ahead and contact the posterior lateral arch of posterior to the TVP of the atlas, and I'm going to rotate the patient's face away from the contact side. So if I'm pushing on the right side, I will be rotating her left and vice versa. A P to A on the atlas contact restriction indicates posterior side of the atlas. Applying the information to the listing side, anterior, posterior. If the listing side is on the right, but the left side of the atlas is posterior, the listing side is anterior. So for the spinal segment portion, I'm going to go ahead and contact her mid-thoracics, and I'm going to contact 3 different segments right here. And for posteriority, I'm going to flex and extend the body while feeling the tips of the spinuses or in between the spinuses on smaller bones and cervicals. They should separate on flexion. If they do not separate, the upper segment is posterior. Okay, so now for rotation, my middle finger will contact the segment, and the index and ring fingers on segments above and below if possible. I will rotate the patient right and left. If the segments do not separate, nose points to the listing, right or left. The patient is rotating right and there is limited movement, then the patient is a P-R. For the lateral wedge, I'm going to go ahead and contact the spine at above and below the involved segment, and I'm going to go ahead and flex the patient to the right and then again to the left, and I should feel a curve in the space. If it feels flat or the vertebrae remains stacked, then the open wedge is on the side toward which the patient is leaning, S or I. Now for the SI joint, I'm going to first determine which side it's going to be. I'm going to do a twist and a bend of the patient. So I'm going to contact across the SI joint. My index finger is going to be on the opposite side of the PSIS. Okay. And then my SIF is going to be on the sacrum, and I'm going to go ahead and rotate the ipsilateral shoulder backwards. This should produce movement in the SI joint, and if not, then I'm contacting the subluxated ilium. So let me go ahead and index finger on the PSIS, SIF on the sacrum, and rotate this way. And yes, okay, now can you go ahead and stand up for me, please? So now I'm going to assess the bending portion of how to determine which side is affected. My thumbs are going to be on the PSIS's superior margin, kind of like the shelf of the PSIS. My patient's going to bend forward, and the side that moves up first and stays higher is the subluxated side, giving you the right or the left. And if there's an uneven early but even at the end wobble, it will indicate a sacrum. So let me go ahead and demonstrate this right now. Go up and lean forward for me, please. Okay, and back up. All right. To determine whether it is a PI or an AS of the sacroiliac joint, I'm going to observe the bottom edge of the gluteal muscle, the bearing muscle atrophy or short leg. The higher glute would indicate an AS ilium, and a lower glute would indicate a PI ilium. So now I'm going to go for a mechanical motion, and I'm going to put my thumb on the involved PSIS. There we go. And I'm going to put my other thumb at the center of the sacrum. S2 would be, I'm using S2 for this case. I'm going to have my patient bring up the same side leg. Can you please lift your right leg for me? Okay, and down. The thumb on the ilium should move slightly posterior, inferior relative to the sacral contact. If not, it would be an AS ilium. And now I'm going to have my patient raise my opposite leg and put it down. And the thumb does not change the sides. As you can see, I kept my thumb on the right PSIS. And if the patient raised the opposite leg and the thumb on the sacrum did not move inferior relative to the ilial contact, it would be a PI ilium on the involved side, which would be the right side. So let me go ahead and check the left side. Can you lift your left leg for me, please? And down. So this is once again checking for the AS ilium, and now lift your opposite leg, please, and down, and that was PI ilium. I will observe the glute widths at the top of the gluteal cleft. A narrow glute will indicate a narrow glute will indicate an EX, and a wider glute would indicate an IN. And the tips of the fingers on the sacrum, pads of the fingers on each medial PSIS. The patient's involved leg will be in a neutral position relative to the adduction-abduction arc of the knee. Medially. Okay, so that would indicate whether or not it was an IN. And laterally, and this would be an EX.